Hi, everybody. Good afternoon, and thank you for joining us. My name is Brian Mustanski, and I'm the co-director of the HIV Implementation Science Coordination Initiative, or ISCI, which is funded by NIH through an administrative supplement to the Third Coast Center for AIDS Research as part of the federal Ending the HIV Epidemic initiative, also called EHE for short. As part of our mission to develop and disseminate generalizable knowledge to help end the HIV epidemic, we present our webinar today on implementing eHealth interventions to end the HIV epidemic. The webinar series, led by ISCI, is designed to bring together researchers that have been supported by NIH EHE supported funding to share project outcomes and discuss actionable strategies for implementing HIV interventions. If you'd like to find out about our future webinars conducted by ISCI, as well as some of the webinars conducted by the Implementation Science Hubs, you can join the ISCI newsletter, and we will put the link in the chat shortly. And to maximize time we have for the presentations and for discussion, I'm going to go ahead and introduce our speakers today. They include Dennis H. Lee, who is an assistant professor at Northwestern University in the Center for Dissemination and Implementation Science and the Institute for Sexual and Gender Minority Health and Wellbeing. Through ISCI, Dennis develops tools to support researchers and practitioners' use of implementation science methods to create generalizable HIV implementation knowledge. Jessica Montoya is an assistant professor in the Department of Psychiatry at the University of California, San Diego. She's a licensed clinical psychologist at UC San Diego Owen Clinic, a clinic that provides care for people living with HIV, and a member of the consultation team of the UC San Diego Dissemination and Implementation Science Center. Dr. Amanda Castel is a tenured professor of epidemiology at George Washington University Milken School of Public Health and Pediatrics at the School of Medicine and Health Sciences. She'll be joined today by her co-PI on the project, Dr. Karen Ingersoll, who's a board-certified clinical psychologist and professor of psychiatry and neurobehavioral sciences at the University of Virginia. Dr. Ingersoll will also provide additional insight through her extensive experience developing and implementing digital interventions for various health conditions, including around HIV care. Throughout the presentations today, you can submit any questions through the Q&A function on Zoom, which you can find at the bottom bar of the Zoom window. Questions will be answered after the presentation, and we'll have a brief discussion that I'll be moderating amongst the presenters. Then we'll open it up for questions that are submitted by the audience towards the end of the webinar. If they're short questions, the speakers might be able to answer them directly in the chat, and we'll hope to get through as many of the questions as we can in the time that we have available. And with that, I will turn it over to Dr. Dennis Lee, who's going to kick things off.
Thank you so much, Brian, and good afternoon, everyone. Again, my name is Dennis Lee, and I have the honor of providing some contextual information. This is an implementation science webinar, and so we do love context. And I'll be telling you about kind of the state of digital HIV intervention implementation in the US as of now. But first I want to highlight a little bit the role that most digital interventions play in HIV. We know very well that to keep someone who may be at risk for HIV negative, one of the most effective things that we can do is get them on pre-exposure prophylaxis or PrEP. And for people who have HIV, substitute antiretroviral therapy for PrEP. But we also know that it is not that simple. We can't just have people show up at a clinic and they get their intervention and we achieve 100% clinical outcomes. And there's a whole bunch of reasons why that is, a bunch of social and structural reasons, small and large, all the way up to things like racism, homophobia, and other stigma. And so in our field, in HIV, we have a plethora of what we call adjunctive interventions or supporting interventions that help people get to PrEP or treatment and then stay on PrEP or treatment. And an example of adjunctive intervention is, for example, patient navigation or PrEP navigation or treatment navigation, someone who is there to help clients and individuals navigate the healthcare system, motivate them to utilize the healthcare system, and stay adherent to their medications. Now, most digital interventions in HIV also serve this type of function. By themselves, they're not going to affect an individual's serostatus, but they serve to reduce barriers to access, increase motivation for uptake, and encourage consistent use over time. There's growing recognition in the larger field of implementation science that adjunctive interventions are very distinct from implementation strategies, which act on the delivery system, not the client, whereas adjunctive interventions, to reiterate, act on the client, not the delivery system. And if you would like to know more about this particular categorization, ISCI published a paper earlier this year in implementation science related to that. So that's kind of the role that digital interventions have historically played in HIV. But long before we even called them adjunctive interventions, HIV researchers have really espoused the benefits of using these digital tools for a number of potential benefits. They can increase accessibility and reach, particularly to populations that may not be widely visible or are just harder to reach in general, or have like geographic distance. Digital tools can be well integrated into people's lives. They provide new design elements like gamification that can help enhance the effectiveness of these interventions and the information that's being conveyed through them. They can be a little bit more efficient and scalable for not a lot more cost. You can ideally scale these things to a wide audience. And then because they're pre-programmed, they may also help with intervention fidelity. So a lot of different reasons why digital tools can serve this function of adjunctive or support very well. So what is the current state of the science on these digital interventions? Well, here are a few things that we know to be very true. The funding agencies, particularly the NIH, have invested hundreds of millions of dollars in developing and testing digital HIV interventions over the last 2 to 3 decades. And for evidence of this, I'll refer you to some really great reviews by Music et al. And some others, as well as NIH Reporter. For example, NIH spent about $108 million on telehealth HIV grants in FY 21 to 23. We also know that a plethora of digital interventions have been found to effectively reduce behavioral and biomedical HIV risk and or increase their use of preventive behaviors. And I'll refer you to the CDC Compendium of Evidence-Based Interventions for HIV. I think there are about 43 across different pillars that have shown to be best practice or promising interventions that are digital. And Target HIV also lists about 14 supporting interventions for care engagement. However, we also know that few to none of these interventions are supported by the CDC and HRSA for real-world delivery. And for that, I'll refer you to the CDC EHE website, formerly known as High Impact Interventions, as well as all of the various requests for proposals that are put out there. There are none that are like properly packaged and disseminated through the websites for people to actually use. And we realize that this is not an issue of effectiveness of these interventions, because we clearly have effective evidence, but it's an issue of implementation. And so our team has been asking for many years why that is and what can we do about it. So in asking these questions and drawing from our own experiences, as well as conducting a literature review, and then surveying 47 HIV eHealth researchers, we've started putting out a path, or trying to identify a path to move HIV eHealth implementation forward. And this was published in a paper also earlier this year called "Your Package Could Not Be Delivered: The State of Digital HIV Intervention Implementation in the US." And our packages, like the current state is that our packages or our eHealth interventions are not currently being delivered. And I'll walk you through this figure bit by bit, which is what we primarily present in this paper in a slightly more clip-arty form. I think a number of challenges kind of lead to why these packages are not reaching their current destination or their desired destination, which is the recipients in our communities. First, just historically, many research teams and funding priorities have not focused on implementation. And so we have what we call this intervention science loop, where a lot of teams are really focused on developing and testing interventions. And there have been limited incentives over time in the past to move to implementation. With this kind of more recent focus on implementation, particular implementation research, I think there's a little bit more incentive there. Um, but there's still a lot of research teams going into this intervention loop cycle. Once those things are developed, though, they kind of enter this compendium of effective interventions warehouse. And then the individual research teams so far have been the ones that have been carrying forward through this long implementation preparation journey. And to even get an effective intervention ready to implement, not even true implementation or full implementation, there are a lot of barriers that they encounter along the way. For example, there's a lot of lack of knowledge or clarity about this whole pathway altogether and how to prepare for and get to implementation. So this whole kind of pathway or journey is a bit of a mystery to many folks, especially given that many of us are trained in developing interventions and trialing interventions, but not necessarily implementation. Moving out of the technology out of university platforms into something that is ready to go for real world use is always a challenge. And this was identified by a number of the developers that we had surveyed. Ideally we would like our technologies that we test to integrate with familiar, scalable, and secure systems, but that's not always the case, particularly on small grant budgets when you're developing with bespoke systems. So trying to take a whole bunch of code and then move it into something that is widely scalable has been a challenge that has been identified. And then maintaining that technology as well as the intervention content over time is also a continued barrier, especially when both of these things are fast moving. We know that programs change, websites change, apps change all the time, and the standards that need to be met with those, as well as in HIV, our interventions and our brick and mortar interventions are always changing. So there's always a lot of new stuff coming out, and it takes dedicated resources to sustain not only the technology but also the content in them. Now, there's also a barrier of developing the right implementation strategies to train and support community organizations to adapt, adopt, integrate, and deliver these interventions. And that is represented on the flip side as well, that many deliverers currently don't have a lot of experience with digital interventions, nor do they have really the infrastructure to host the digital interventions themselves. So even if you packaged an eHealth program and then handed it to them, very few would be able to bring it up and running on their own. Similarly, when we think about recipients or clients, they don't have a lot of experience doing digital interventions, and there may also be health and technology literacy challenges. And so on the researcher side, identifying how to best motivate and support the recipients to use the intervention with sufficient dose is also a challenge that needs to be thought through along the way to just prepare these interventions for delivery. Now, implementation science as a field can and as has been going on for a number of years, is developing and testing strategies to help clear out some of these barriers, or at least make them a little bit more easy to get around. But there comes a point where that we have identified that where the research teams themselves can go no further without more support from the delivery system. There's as we identified in our paper, there's not enough technological infrastructure, there's not enough funding for implementation of these interventions, and there's not enough delivery or deliverer support. And so to kind of close us out and kick off the rest of this webinar, we proposed in the paper kind of a path forward that requires using implementation science to help bypass many of the barriers that are encountered early on in the preparation journey, but then also some agency action to help build the bridge that links the research teams to deliverers so that we can together carry forth our packages, our eHealth interventions to the communities and the recipients that they're meant to serve. And I look forward to discussing this further with the other speakers in the Q&A.
Thanks, Dennis, for providing that excellent overview of some of the implementation questions and challenges in the digital health space. Now we're going to hear about a specific study that has elicited some of that information about some of the challenges of implementing digital PrEP adherence tools. Dr. Montoya.
Thank you for that introduction. So I will be speaking specifically to a single site 1-year EHE funded study where we engage the community to inform the implementation of a technology-based intervention that is intended to support PrEP adherence and persistence. So one of the implementation gaps that our adjunctive intervention is really trying to fill is this issue around PrEP adherence and persistence. So I just want to quickly present this published data that looked at pharmacy refill from a national chain and involved about 7,000 individuals who were prescribed PrEP in 2015. And what this graph is showing is that when we look at a year out, about 57% of men are still prescribed and refilling their PrEP, and it's much lower for women at 34%. And then at the 2-year mark, we see that only 42% of men are maintaining their PrEP prescription refills and 20% of women. So this data, is raises a lot of questions. There may be people who no longer have indications for PrEP, and therefore it makes sense that they discontinue their PrEP refills. But for many people, this may really indicate that they are having some difficulty adhering and persisting on PrEP. And it could be due to a myriad of issues, whether it be insurance coverage or just their availability to maintain going to PrEP provider and lab visits. So our adjunctive intervention for PrEP adherence and persistence is the individualized texting for adherence building, or referred to as ITAB intervention, which is a personalized text messaging system that supports PrEP adherence and persistence. It is recognized as an evidence-based intervention in the CDC Compendium of Evidence-Based Interventions. And on the right-hand side here, you see kind of a snapshot of what that intervention looks like. So it's a text messaging-based intervention, and there's been various iterations of ITAB. Some that offer kind of just fun factoids, others that are more kind of health promoting messages. But in this specific example, it's a fun fact. And the person is asked to reply yes, no, postpone. And during kind of the enrollment period for ITAB, they are taught that those reply options are intended to indicate if they took PrEP that day. So this participant says yes, and then they're given a positive reinforcement message. On the bottom right, you see kind of the algorithm for how this text messaging intervention works, where essentially it's a personalized adherence reminder. They're given different response options and then either given a personalized reinforcement message or encouraged to take their PrEP as soon as possible. As the introduction of this webinar suggested, a few studies have explored and tested how to promote the adoption of technology-based interventions in community-based organizations, and because of that, for our 1-year EHE supplement, we really were focused on exploring how to move ITAB to real-world settings. So again, the aims is to support PrEP adherence and persistence. We specifically have an interest in working with community-based organizations. For our EHE supplement, we partnered with the Los Angeles LGBT Center. They have been involved in a lot of the demonstration projects for PrEP and have also utilized ITAB in research-specific studies. And so it really seemed like a natural transition to see how they could offer ITAB outside the context of an efficacy trial. So our first aim was to really understand if ITAB is an acceptable, appropriate, and feasible intervention. And this is going to be based on the perspectives of both clients and personnel, the LA LGBT Center, and then to really understand the implementation determinants or the barriers and facilitators of ITAB adoption at this specific center. In regard to our implementation science methodologies, part of our work was really to familiarize the research team, both sides of the equation, so the UCSD partners as well as the LA LGBT partners on the EPIS framework. And that helped kind of inform where we were in our phases of implementation and the data that we collected. This study largely involved mixed methods data collection. So we are presenting data from 25 clients and 11 personnel, which included providers, staff, and directors of the center. And then we also gathered qualitative data from our periodic reflections that we conducted during the last 5 months of the study period, which really was a great opportunity for the implementation team to, one, interpret the data that was incoming and to consider kind of what our next steps in the process was. As it relates to AIM 1 findings, again, we were looking at whether the intervention was acceptable, appropriate, and feasible. We did use the pragmatic measures of acceptability, appropriateness, and feasibility that are widely used in EHE-funded projects. And by and large, our ratings of acceptability, appropriateness, and feasibility were high. So it's on a scale of 1 to 5, 5 indicating greater acceptability, appropriateness, and feasibility. The only marker here that was on the lower side was the appropriateness measure from the clients. And that really had to do with our recruitment procedures. A lot of the people who were involved in this study were actually pretty good at adhering to PrEP already. And so for many of them, they would say something to the effect of, you know, I already have established this as a habit, but I could see for other people who have a hard time with day-to-day adherence that this would be a really great intervention. So it wasn't that the intervention itself wasn't appropriate broadly, but more to which specific clients could benefit from this adjunctive supportive intervention. In terms of the qualitative feedback, we received very positive responses when we presented the ITAB intervention, and they noted several appealing components. So they liked that the message content could be customized, that there were different themes or domains that the messages could speak to, and that clients had the ability to set the schedule by which they would receive the text messages. They also liked that the content was very positive in nature, reinforcing of their behavior to take their PrEP, and very affirming. They also liked that you could choose level of discreteness, so whether or not your messages spoke directly about HIV prevention or even PrEP specifically. They like the interactivity, so this is not a one-way messaging system, but rather it has been built to be a two-way messaging, and that it could provide a record of their day-to-day adherence to help with accountability. And then contextually, our EHE supplement was conducted in 2020. So this really did align with the general transition to telehealth-based services during the onset of the COVID-19 pandemic. In AIM 2, we were looking specifically at implementation determinants of ITAB adoption. Here, I'm going to extend that metaphor of road barriers and then kind of bridges or facilitators of implementation. So on the left-hand side here, our barrier, one barrier that was identified was the intervention specificity. So ITAB was really intended to facilitate day-to-day adherence to PrEP. And many people that we interviewed said that they thought that clients could benefit from text messages that prompted them to get a prescription refill or to remind them of an upcoming appointment, including to obtain their lab visits. And so kind of a facilitator or strategy to mitigate this barrier was to promote adaptability of the intervention. So having ITAB message that could remind people about appointments, that could even speak to other non-PrEP related concerns, such as mental health. And then kind of to give you a little bit backside on the ITAB, we do have this calendar view visual of kind of their day-to-day adherence. But in our research studies, this was really kind of on the back end that the research coordinator would be able to see. And clients really wanted that to be something that was accessible to them. Another barrier to ITAB adoption was that the adherence data is not already integrated into an existing EHR system. And really kind of processing this data in our periodic reflections, we really kind of had to consider the purpose or the utility of integrating ITAB into the EHR and whether it was actually desirable by various stakeholders. We get a lot of this feedback from providers saying, you know, if I'm the one who's responsible for signing someone up for ITAB, I don't really want to have to click outside of the EHR. But that's really a consideration if you think it's going to be the provider or the prescriber who's linking participants to ITAB. But if you have another kind of person who's involved in the enrollment process, this integration with the EHR may not be necessary. And we actually heard from many clients that it was maybe not even desirable, that they wanted their adherence data to be their own and not necessarily shared with their provider. This also led to many discussions around how to develop resource sharing agreements. So one was to explore how to integrate ITAB into the EHR if that's the direction they decided to move in. So that could be the UCSD-based intervention developer sharing the intervention code and content with the community-based organization so that that center itself could do internal development of the technology. Aim 2, again, this is more implementation determinants. So another barrier was general lack of provider awareness that ITAB exists and kind of not being aware of its function and purpose. So a very clear implementation strategy to overcome this barrier was to conduct educational meetings, particularly meetings that already happen, so that you really are not trying to create an extra hour in someone's work schedule, but rather provide the educational experiences in a meeting that they already kind of hold, that they already hold on a weekly basis. When we looked at our quant data, and this is the implementation climate scale, we did see that personnel rated the center's focus on evidence-based practices fairly high. It was a scale that actually had the highest mean score. But when it came to educational support of EBP, on the far left-hand side, you see that that's actually one of the lowest scores. So this seemed like kind of the perfect place for implementation scientists to intervene in this specific setting. And then other barriers that emerged in our qualitative interviews was that there's no set strategy for increasing client awareness of ITAB and no set protocol for enrolling them in ITAB. So we identified a couple of implementation strategies that could work in this center. One is to identify and prepare champions. So a center like the LA LGBT Center already has PrEP navigators, and this seemed like a natural extension of their role was to promote and support ITAB implementation. So they seem to be very enthusiastic about being trained on how to use the text messaging intervention, how to use the customizable components and link our clients to this intervention. Another strategy was to kind of really address this direct to consumer approach. So increasing demand for the intervention on the client side. And this could entail creating advertisement material, such as client generated videos. TikTok was kind of becoming very popular in 2020. So that was often mentioned in the interviews. And then consider developing a web page where clients could self-enroll. So kind of even maybe potentially cutting out the middleman of the PrEP navigators and allowing clients to self-enroll. Especially this could work if they were first aware of ITAB in the first place. So to summarize lessons learned from our 1-year EHE supplements, I think the very first crucial ingredients to understand your implementing partner's values, their initiatives, kind of what's going on within their context at a given time, and their funding sources, both currently and kind of what they have access to apply for. There's always this balance, I believe, that will take place with any intervention, which is to promote adaptability to fit the needs of the specific clients, but also to balance what is necessary to preserve fidelity. There are various ways in which data resource sharing agreements can be worked up. We explored a couple of possibilities, and that can look, I guess, very different depending on who the intervention developers are and who is trying to implement the intervention itself. Educational meetings kind of come up as the kind of easy thing that's achievable. People often already have many meetings throughout the course of the week, but it's learning how to use that time effectively and being able to provide education about an intervention that is easily digestible and actionable. In this specific setting, we do have PrEP navigators, so they seem to be really the clear champions of adjunctive interventions, but there's also value in potentially increasing client demand for interventions. So with that, I'd like to acknowledge my UC San Diego team, especially David Moore, who is the developer of ITAB, a couple of our graduate students who helped put together this presentation, Vanessa Serrano, Maximo Prescott, our LA LGBT Center colleagues, especially Risa and Bob Bolin, and then our implementation science coaches. Thank you.
Thank you so much, Dr. Montoya. And with that, we will proceed with Dr. Castel and Dr. Ingersoll.
Thank you. Okay, well, thanks everyone, and good afternoon. I'm going to be presenting on behalf of myself and Dr. Karen Ingersoll. We are MPIs on this study, which is a pragmatic efficacy trial of eHealth to improve HIV outcomes in the DC cohort, and it's been funded by NIMH. So I'll briefly go over the DC cohort, what it is, and the Positive Links app, and our efficacy trial aims. And then I'm going to highlight some results from some formative research that we have completed on the study, focusing on patients who are living with HIV, providers, and as well as looking at some baseline organizational readiness for change results. I'll share with you where we are in the course of the study, and then talk about some of the challenges and successes that we've faced thus far. So first of all, just to understand the platform from which the study is being conducted. So the DC cohort is a NIAID-funded study of consenting people with HIV who are receiving outpatient care at 14 different clinics in DC. We collect all of their information in the course of their care, ranging from their risk factors and diagnoses to their labs, all treatments and procedures that they receive at their particular clinic. It's a citywide initiative, and so we have a very wide range of clinics participating, most of whom are academic or community-based clinics, and then we have one government clinic, the VA in DC. As far as we know, this is one of the largest HIV cohorts to date. We have over 13,000 people enrolled in the study, and when we compare our data to the surveillance data in DC, we know that we have a representative sample of people with HIV who are receiving care in the District of Columbia. We also have a clinical dashboard, which allows us to monitor patient outcomes and to improve patient care. And through that dashboard, we found that, for example, although we have over 13,000 people enrolled, about 50% of those people are routinely engaged in HIV care. And so last but not least, really importantly in this context, the cohort serves as a public health and research resource. So we are a network and a platform for testing interventions, and that's why we are partnering with Dr. Ingersoll and her team on the Positive Links study. So Positive Links is a mobile health platform that was designed to improve retention and care for people living with HIV. It was pilot tested at the University of Virginia in 2017 and had indications that people who used positive links had increased viral suppression, had higher CD4 counts, were more engaged in their care. And since then, the app has been expanded and is now being used in 6 states and in 2 other countries. As discussed, it is a CDC evidence-based intervention. It was designated that in December of 2019, and there are around 900 users of this app throughout the Ryan White Clinic system in Virginia. Many people who use the app daily and some who've actually used it consistently for ongoing now for 9 years. On the right-hand side, you see some of the app features, but I know that that's small, so I'll just tell you briefly what they are. When people, users of positive links have access to a biometric login, they receive daily check-ins asking them about their mood, their stress, and medication adherence. They're asked how they are, and there's a dashboard similar to what Dr. Montoya showed, which shows the calendar of their responses over time so that people can kind of self-monitor how they're doing. There's a community message board, which has been shown to be very active. People have anonymous profiles in PL, and they're able to speak with each other and kind of share their experiences, whether they're related to their HIV care or how they're feeling that day. And then there are also resources available to them that provide information on various aspects of living with HIV, an FAQ page. There's a private messaging feature so that participants can actually message with their healthcare providers directly. They get weekly quizzes. There's a feature to allow for documents to be uploaded. So for example, if someone wanted to renew their Ryan White or I don't know, it's some kind of benefit, they can do that securely through the app. There's a way to contact people who work at the clinic through the app. And then, as I mentioned, every person has their own profile page where they can set up an avatar, that biometric login. They can decide when they want that medication alarm. And then last but not least, there is a page that shows a numerical and graphical view of people's CD4 and viral load trends and helps them to interpret them over time. So this is an extremely robust app. It had been tested primarily in a rural setting in Virginia and not really tested in a racial or ethnically diverse population. And so we thought it would be a great idea to test the efficacy of positive links within the DC cohort network of sites. So these are the aims for R01. The first was really to adapt the PL app to the DC cohort context, and that's what I'll focus on today. The second is to conduct a cluster randomized efficacy trial. And our primary outcomes are viral suppression at 12 months and retention and care at 12 months. And then our third aim is really focused on an implementation science evaluation. So identifying best practices at the site level, at the patient, provider, and system level, again, using these implementation science approaches. So again, I'm really going to focus on some of the aspects that we use to adapt PL. I'll talk about the first 4 briefly. The last 2 were user testing and beta testing, but we're in the process of publishing those data. And so once that paper comes out, I'm happy to share those results with everyone. So we conducted focus groups, individual interviews, and then we also conducted 2 focus groups with the DC Regional Planning Council, essentially. We really wanted to get a diversity of perspectives on how people identify barriers and facilitators to engagement and care, what their perceptions were about the use of technology to support engagement and care, and then specifically to share with them, what PL does and to understand any questions or concerns they may have as we integrated it into the DC cohort network. So on the left-hand side are the barriers, facilitators, and perceptions around technology and PL that providers provided. On the right-hand side are those of patients who were receiving care for HIV. I'm going to focus on the bottom, which is really the overlap that we saw between providers and patients. So for barriers, there was definitely commonality around engagement and care and issues around mental health, stigma, substance use, and low health literacy. But facilitators of engagement and care, it's expressed by both groups of both groups of people, included the ability to have positive relationships, but also to have social supports to be able to remain actively in HIV care. When we focus specifically on technology, some of the advantages of being able to use technology to improve engagement and care included being able to connect with the care team and to be able to more easily access information. But a disadvantage that came up across both groups was really, people being technologically savvy, right? How easy or difficult is the technology to access and to use? And when we asked these groups of individuals, what technologies they were using, many of them referred to the electronic health records, to patient portals that they were able to use, as well as to various health apps. We did this formative work in the midst of the COVID-19 pandemic as well. And so there was a lot of use of the EHRs, there was more telehealth use emerging, but there were also some kind of informal ways that people were corresponding with their patients and providers through things like WhatsApp, for example. We asked them specifically about what they saw as benefits of positive links after we gave them kind of a demo of the app. And people were excited about the potential to improve their health literacy and health knowledge about HIV. They really liked the ability to potentially communicate with each other, communicate with their providers. That community message board was very intriguing to people in terms of their ability to connect with other people living with HIV. And really felt like this would be an opportunity to provide them with more self-efficacy, to empower them. We highlighted some of the features of PL, including its privacy and security, and those were also seen as positives. There was some concern about the literacy of the population that was going to be using the app. And there were also some concerns about privacy and security. But I would say one of the biggest hurdles that we had to face was this redundancy with current systems or processes that were already in place, again, as they related to having access to an EHR or a patient portal, where some of the same types of features were available. When we asked about suggestions as to how to implement positive links in the DC and the DC cohort context, we got a lot of feedback about adding additional resources, making sure that we had site and local resources available. And also, interestingly, patients wanted this to be a more holistic app. They really wanted us to add additional reminders about like other healthcare needs or other things that they needed help managing in life. And so we took all of that into consideration. And we also surveyed our sites just to, again, try to quantify some of the characteristics that the sites had or to characterize, the sites as they related to technology use. So as I mentioned, we have a variety of different sites, community-based, academic, and federal. We asked them about different supportive services that they had for engaging in care. You can see that most offered some type of case management or adherence. We also asked them about their baseline mHealth and technology use. Again, we were doing this in the context of COVID. So for most sites, many were using telehealth or telemedicine to conduct visits. Providers were certainly using EMR-based tools to message with patients. And then, as I mentioned, they were also using some non-EMR-based tools to really try to stay connected with their patients during this time period. So after we gathered all this information, we met with the site PIs and went through all of the different features of positive links. And so here is basically the decision that that collective group made about what features would be core to the intervention and which ones would be optional and which ones we would exclude. So the 4 core features were the check-ins, the resources, the FAQs, and that community message board. The sites decided that messaging and the document upload and bi-directional sharing of information would be site-specific. We were not able to integrate the lab feature into the cohort study because we have 5 different EHRs that are used, and so that was just going to be technologically challenging. And the site PIs decided that we would exclude the appointments and reminders feature as well as the telehealth features because they felt like those were redundant. We have English and Spanish versions of the app available, and those are dependent on participant preference. We did add in local and clinic-specific resources. As I mentioned, we modified how we would deploy the labs, appointments, and telehealth features. And since we've actually launched the RCT, we have actually done 2 additional things, which are streamlining the way that participants can reset their passwords. And because more people are starting to be on long actings, those daily medication check-ins weren't making sense. And so we had to modify the app for that as well. Really quickly, I just want to highlight some of the baseline data that we have for our implementation science evaluation. So we did look at organizational readiness for change among our 17 providers that are using the app. The point here, I'm not going to go through each of these lines, but just to show you that the overall ORIC score was 48, which means that there was a high level of readiness for change commitment and change efficacy. So as I mentioned, the cluster randomized trial is ongoing. Patients are eligible to be in the study if they basically are not virally suppressed, are poorly engaged in care, or newly diagnosed. We follow them for a 12-month period, and we will have follow-up data on everyone by May of next year. But just really quickly, you can see that we do have a kind of older population. The median age is 53. It's 58% male, and we have about 83% of our participants who are non-Hispanic Black. We're also starting to collect our implementation science outcomes data. So we'll be doing a series of provider interviews, RA interviews, because they are integral to the way that we implement the study, as well as focus groups or IDIs with people living with HIV who had access to the intervention. So I know that was really quick, but I just want to highlight some of the challenges, again, that I've mentioned before. So this redundancy with existing technologies, we really have felt this competing use of these electronic health records and patient portals with the use of the Positive Links app. And so we really try to highlight the added benefit of using PL. The fidelity of implementation has been interesting. So even though it's being used in kind of a real world context in Virginia, we are implementing in a research context in DC. And so we have the sense that we've had limited clinic level buy-in, which is a little bit different than the experience that Dr. Ingersoll can discuss. And also in terms of the champions for Positive Links, it's really been the research assistants. And so that can be variable in terms of their knowledge of the app, their familiarity with it, the uptake and use of the app. But all that to say that we think that we've had several successes. So one is being able to actually take this app and adapt it in this local context. And also to adapt it in a context for research purposes as well. And most importantly, that this is really the first RCT to study Positive Links and its use in an urban context among a mostly minoritized population of people with HIV. So I will stop there, and I just want to acknowledge my huge study team and
Thanks.
Happy to answer any questions.
Yeah, thank you. And it's great wrapping up, ending about the concept of adaptability. And I want to bring Dr. Ingersoll into the conversation. And, I appreciate you sharing, in both cases, some findings that are really just emerging, kind of hot off the presses, things that are coming as you're midway through the project or just wrapping up the project. That's really helpful given the goals of EHE to move quickly, learn, and do. And I want to, bring in Dr. Ingersoll because Positive Links is, I think, really on the forefront of implementation of digital HIV interventions. And we're all kind of learning a lot from what you've done and ways in which it's been implemented. We've talked a little bit about adaptability, and I wonder if you could talk a little bit about how you've approached that. I think there's sometimes this sense that digital interventions are like locked down and that's why sometimes people have some resistance to them, that it won't work in our system, or we want to make these changes to it to work within our system. And how have you approached that? What have you learned about adaptability?
Well, thanks, Brian. Amanda's covered sort of the research project side that we've done in the DC cohort, but I can share that, most of our groundwork was done in the state of Virginia. Early on, we knew we were dealing with a large, rural, diverse state with a few cities, but where we were really having the most demand for some kind of app to keep people better engaged with their HIV care were from our rural and suburban HIV clinics. And so we ended up developing a community of practice program where, as we enrolled sites and their coordinators, we invited them to be a part of our monthly community of practice. And so every month, our program manager gets together all the site's staff who want to participate, and they are sharing actively best practices, also things that didn't work in terms of them trying to enroll their patients and reach out to people. As Amanda shared, in the DC cohort, there were already a lot of EHR based and other kinds of communication tools that patients were using. But that really wasn't the case when we started with Positive Links in Virginia. Even now, even though more people have EHR related tools for communication with their care team, at least in Virginia at the sites in the rural areas, patients prefer to communicate through Positive Links. And so that's, that is good, but it's also involves some challenges in terms of really making sure that the clinic teams are on board. And even at our own home clinic at the University of Virginia, a minority of the physicians are on the app. It tends to be more the case managers, community health workers, people involved with outreach and re-engaging people in care. And that's really what we see in the community of practice as well. Folks who are using it on the staff side the most are those who are really trying to stay engaged with the patients and keep them, in care and deriving the benefits of care.
Yeah, and I think that speaks to what Dennis had said at the beginning about the concept of adjunctive interventions, and that a lot of what produces success in HIV prevention and care is not limited to what happens in that clinical encounter, that there's a lot of other adjunctive interventions and strategies that have to be integrated for, success and engagement, re-engagement, persistence in care. We talked a little bit about integration with EHR. Jessica, you spoke a little bit about it with your intervention as well. And Dennis, I know we've done a little bit with some of the preventive interventions around different platforms of which to deliver. Just for the sake of, we only have a couple minutes left, maybe Jessica and Dennis, if you want to say anything more, any additional thoughts you have about integration into existing platforms versus things standing alone, or how researchers might think about approaching that. Dennis, do you want to go first?
Sure, I can hop in with a quick thought. I think a lot it is challenging, but I think a lot about design. Those folks who are still kind of early on and have an idea for or identify a need for a new digital intervention. even though it may not be their first, excuse me, their first necessarily go-to design for something like Canvas or some other kind of very widely used, but maybe not the most flashy platform. If they keep in mind kind of designing for implementation or designing for sustainment, that might help steer you toward those developers towards a platform and creating content for a platform that will more easily be transferable to something later on.
Jessica, anything you want to add to that?
Yeah, I mean, I think having maybe the setting and kind of the actors in mind from the get-go. So I think EHR integration makes a lot of sense if you have a specific setting that you know you're going to be implementing in, and that the investment of actually integrating into that EHR has a clear payoff. I think for our intervention, it really was meant to be a little bit more kind of global and not EHR specific. And so I think you always run into the issue of there's multiple EHRs. Do you build for all EHRs? I don't think that that's feasible. So it's really kind of have an idea of what is the specific setting.
Great. Well, just to respect everyone's time, I want to leave that as our last word and thank our presenters. I have to say personally, as someone who's worked in this particular space for about 20 years, I'm really excited how the field is really starting to grapple with these questions of implementation. And, you know, we've done a lot around demonstrating these digital interventions can work, they can be scalable, but we now need to really solve the question of how do we sustain them and support their reach to the people who need them most. So I'm excited to hear these findings that are coming out of your project, and certainly Karen and Amanda, as you get the results of that RCT, we'd love to hear more from that phase as well. So I want to thank our presenters today, and thanks to NIH for supporting ISCI in many of these projects. I want to mention that the webinar recording will be available on the ISCI website in the next few days, along with our prior webinar on PrEP interventions with Black communities. If you sign up for our ISCI Interchange newsletter, you can get up to date about new tools and resources that are coming from ISCI and the hubs, as well as future webinars that we have. So thanks everyone for joining us today and for our really fantastic presentations.